Yes, the 1A is a 7-year-old female dachshund with pituitary-dependent hyperadrenocorticism before treatment with mitotane. Look at B. That's the same dog? Yes, it is. But the problem is that we lost all the hair coat. And this is one of those black and tan dachshunds, and so you lost all the black hairs. And all you have is the skin underneath. I'm not lying. This is not two different dogs, okay? All right. The reason I hope y'all don't mind the pictures, but I think sometimes it helps it, like I say, stick, if you can see. All right, now you can also use another drug called crystalstain or veteril. It's the first approved for use in dogs by the FDA in 2009, and it's the first drug that was been approved to treat both pituitary and adrenal-dependent Cushing's in dogs. But what's that last statement say? Lifelong. In other words, you can never take the animals off of it, but you try to get the minimum dose to maintain normalcy, okay? And what it does, it blocks the excessive production of cortisol by reversibly inhibiting the action of the enzyme 3-beta-hydroxysteroid dehydrogenase, and that is the, remember those, and when we talk about producing steroid hormones, we had those pathways that showed the different enzymes and what you get different steroids out of it, and so that's one of the steroids involved with that. But one thing, it also inhibits aldosterone synthesis. So what do you think you're going to have to do? In other words, it's going to have to really give supplementation for the mineral corticoids usually with this. And your most common side effects are reduced appetite, vomiting, diarrhea, lethargy, and weakness. You can get some more severe effects that are severe depression, hemorrhagic diarrhea, collapse, adrenal necrosis, and rupture. And what does that usually result in? Death, or DDD, right? Dead dog disease, right? Can't say DCD because it's not approved for use in cats, so we wouldn't use it in cats, right? There's also another one, Epinephrine or Cilian, which is FDA approved to treat Cushing's disease in dogs, and also canine and cognitive dysfunction syndrome, which is another nice fancy scientific term for senility. I mean, my husband and I are having some problems with this. Not canine, but human cognitive disorder here. But it's used in humans for the treatment of early stage Parkinson's disease, depression, and dementia. But it's usually used to treat uncomplicated pituitary dependent Cushing's. In other words, you don't have diabetes mellitus or anything like that that's developed in them. It increases the concentration of dopamine and high serum levels. This drug will basically affect steroid biosynthesis by interacting with the structure of the steroid molecule and break down, so you don't get the, the steroid hormone, the glucocorticoid being formed. Okay, inhibits its synthesis. You can't use it in pregnant and nursing animals because you can get very serious side effects that include difficulty breathing, hives, agitation, swelling in the lips, tongue, or face. Not only in the mother, but in the nursing pups also. All right. Ketoconazole is another drug. It's more expensive than mitotane. It's not always efficacious, so we don't use it as much, but it's the one that's used more often as far as horses are concerned. But again, you will see people, it's a broad spectrum antimycotic drug, and for basically it inhibits the synthesis of glucocorticoids. Okay? Cypriptidine is another one. It's been used with very reason you're getting these is because you will see these on the boards. And I'll ask you, what's the best drug to use, or can you use this drug? And so you have to be familiar with what the drugs are and what they're used for. And as far as cypriptidine, it has anti-serotonin, antihistamine, anticholinergic effects. It causes excess secretion of ACTH, so it's going to increase the adrenal secretory activity. So if we block serotonin, we decrease that production of ACTH. Okay? But has serotonin got some other important, mechanisms elsewhere? And what do you think you're going to do to those functions when you block it? You can cause some significant side effects. That's why it's used with variable success, because sometimes you can end up with worse problems than you started out with. It had nothing to do with your adrenal, but another system. Okay? Metirapone, amyloglutamide, are questionable use in dogs, but again, metirapone, it inhibits the synthetic chain as far as making your glucocorticoids. It got a lot of notoriety a few years ago, and it was supposed to be the panacea to fix everything, and they found out that it's not quite as good as they thought it was. At least as the drug companies thought it was. just because the drug company says it's fantastic, does that necessarily mean it is? And when I worked for a drug company for 5 years, and believe me, it doesn't work like that. Okay? Man, what's the main thing that drives drug companies usually? Money. Okay, now cats, as far as drug therapy, agents that have been used are mitotane, meteropone, and tristothane, but best thing you usually do in cats is surgery. Take out the adrenal glands. Even if it's pituitary dependent, you take out the target tissue, well you do. But when you do that, what are you going to have to supplement that cat with? Your mineral corticoids and stuff. Okay? So usually lots of times in cat, best therapeutic procedure is to take it out. Okay, and then supplement. Now prognosis on dogs with mitotane therapy, remember canine pituitary dependent hyperadrenocorticism is never cured with that because it's affecting the target tissue, right? But it's only managed, and the average survival time is about 2 years. In cats, prognosis is always guarded the grave, as far as this is concerned. Okay, there's another syndrome called the equine pars intermedius dysfunction, and that's just a nice, flowery way of saying basically pituitary hyperadrenocorticism in the horse. Now, what's wrong with this horse? This is summer. Did it lose its winter hair coat? No. And what about its build? Is it look nice and trim, or does it just look totally out of shape? Yeah, totally out of shape. Now, as far as the equine pars intermediate dysfunction, or PPID, again, it's equine Cushing's disease, equine Cushing syndrome. About 99% plus of these are caused because of pituitary dependent hyperadrenocorticism, and you got this functional adenoma up there. It's usually in the pars intermedius, which means it's going to cause more wide range things. Intermedius is very closely associated with the hypothalamus. So it will not only cause problems with the pituitary function as far as glucocorticoids, it can interfere with the normal cycling of hair cycling and everything else up there in the pituitary. And it can also interfere with those dopamine reactions and this type of thing, serotonin reactions. And basically, you're going to get also increase of your melanocyte-stimulating hormone. You're going to get increased beta-endorphins and other products of this. And so they may look like they feel terrible, but they may actually be kind of happy because of the endorphins. But that's masking their severe clinical signs, okay? And basically, you're going to get... if you got too much ACTH being secreted, what's going to happen to the adrenal gland? You're going to get hyperplasia because you're stimulating it like crazy, right? And so basically the combination of these secretory products that this tumor is producing in that area is causing a lot more clinical signs usually than you can see in some of your other species. Okay, a normal equine pituitary gland, again, the melanotropes receive neuronal input from the hypothalamus to release dopamine. And dopamine will then inhibit the intermediate lobe pituitary gland from making and releasing many of those different hormones that are produced by the pituitary. When you have this pituitary, the PPID in the horse, these hypothalamic neurons degenerate, you lose much of the dopamine inhibition. So what happens to all those hormones that would normally be regulated by dopamine? They're no longer inhibited, so you get a lot more problems as far as clinical signs and things. And this is just a diagram showing you that, what's going on, normal, and what happens with your PPID. Notice all the stimulation from dopamine in the normal. What happens to that stimulation down there at the bottom? But look at the size also. What's happening to the pituitary? It's more hyperactive. Because remember, dopamine does what to most of the hormones? Inhibits. Okay? Except for prolactin. Okay, this is just showing you a... pardon me. See the pituitary on the bottom there? On the bottom of the brain there? It's supposed to be that big. And that's because we're getting basically hyperplasia in the pars intermedia. And so you're going to get hypertrophy because it's going to crowd out the rest of the pituitary. Actually, it can. And if you look at the different segments, you can see this. And look down at the one on the cut section. Could that be causing some more other hypothalamic problems? Because is it staying where it's supposed to, or is it going up? What do you think might happen to the neurohypophysis? Brunched. I don't know if that's a really word or not. Brunchosis. Going on in there. Okay. So incidence, PPID, relatively uncommon. It also appears to be more common in ponies than in horses, especially your Shetland ponies and this type of thing. They already have a strange hair coat, so it's kind of hard to diagnose sometimes because of that. It's usually in older horses between 10 and 30 years of age, the mean age of about 20 years. Affects all breeds of horses, but seems to be more common, as we say, in ponies and in Morgan breeds. Okay? Doesn't seem to be any sex predilection for it. As far as your clinical signs, basically anything you see from excessive circulating of glucocorticoids and also physical destruction by pressure necrosis of the pars nervosa, which is the neural hypophysis. So you're going to see problems with ADH and stuff like that? Yes. Many of the signs of PDH are associated with basically interference with the normal hypothalamic function. They don't have regulation of temperature, so they sweat like crazy. Even when it's not hot, they're sweating like crazy. They don't have the normal cycling as far as, molting and shedding of hair with seasons and stuff. They don't do that. That's why they get this shaggy hair coat all year round. Okay? It's the pituitary dependent hyperadrenocorticism, and this is also very active, and so you're going to get, basically increased ACTA, let's see, PUPD, and all the things we saw in the dog and the cat. It's just more pronounced in the horse because of its location and its more effects upon systems other than just the pituitary. Okay? Here's just an example of a long hair coat that fails to shed. What's the term for that? Hirsutism or hypertrichosis. Okay, hirsutism is the one we usually hear. And it's the most common clinical presentation you're going to see with these horses. And it's seen in about 85% at least, which is pretty good to have a symptom that's common in that many cases, as far as your horses are concerned. Also, you can get patchy, slow shedding with or without alopecia. Your guard hairs will not drop out. And those are those long hairs like in the jugular furrow and everything. So you can have 4 and 5 inch long hairs in a horse in that jugular furrow from this type of thing. What about the physical condition? They look normal. You can see we got the pendulous abdomen. They're going to lose weight loss, lose muscle atrophy and stuff like that's going to concern. You're not going to have a nice straight top line like you're supposed to see in horses. It's going to dip like that. And so you can see they just don't look good, do they? All right. PUPD will usually occur, again, because of destruction of the pars nervosa and because of the excessive amount of glucocorticoids that are being secreted. And you also get severe hyperglycemia, and it's going to exceed renal threshold, and what will glucose take with it? It's an osmotic agent. It's going to take water with it. So it's going to interfere with reabsorption of water, so is that going to give you polyuria? Will that stimulate polydipsia? And we'll see all that. And they get a ravenous appetite because, again, is that glucose going in where it's supposed to be going? So what's the satiety center saying? Food, food, food. And so these horses, and they tend to eat just about anything they can come in contact with. There has been cases of horses eating dead rats, which you don't want to think about, but that has occurred. And somnolence. What's somnolence? That's what 3/4 of you are all feeling right now, right? Right. You can get intermittent hyperpyrexia. What's that mean? Body temperature spikes and all that stuff because you're interfering with the thermoregulatory centers. Again, hyperhidrosis can be because of your cortisol-induced release of excessive catecholamines also in the adrenal medulla, and that can give you the sweating as well as increasing hair growth. And since you've really decreased your, you've got all this stuff, you're decreasing your immune ability to fight off things because he's not working very well. But you can set yourself up to, usually you don't have problems with a lot of the fungal agents and things like that because the body takes care of the bacterial agents and it's healthy tissue and everything, right? But when you start getting damage to the tissues and stuff, can you get more fungal infections and things? And some of these could be like nocardia. How do I know that's nocardia? Just by looking at that slide without the labels on it. Nocardia is acid fast. Okay, so is Michael